So let's turn now to Kyle Bernstein and hear what he has to say about bolstering this whole workforce issue.
Thank you so much, Lauren, and thank you to the organizers for inviting me today. Can I just confirm, Lauren, that you're seeing my slides correctly?
Yes,
okay.
Yes, we can see it.
Excellent. So I'm here from the Division of Scientific Education and Professional Development at the U.S. Centers for Disease Control, and I'm going to talk a bit about how we're starting to think about efforts to bolster a national public health workforce, or population health workforce at CDC. I have no financial disclosures, and here's my standard CDC disclaimer. So I wanted to start out by differentiating a bit between population health and public health. So population health can be defined a few different ways. I think this is a really robust and well-appreciated definition of population health, that it's an approach that focuses on interrelated conditions and factors that influence the health of populations over the life course, identifies systemic variations in their patterns of occurrence, and applies the resulting knowledge to develop and implement policies and actions to improve the health and well-being of these populations. Generally, population health focuses on the aggregate or population as opposed to the individual, with the goal of population health to improve the health of groups and reduce health inequities between populations. As suggested by some of our earlier presenters, public health, on the other hand, is a little bit more of a rigid definition. The Institute of Medicine in 1988 defined public health as what we as society do collectively to assure the conditions in which people can be healthy. And in a more recent paper by Diaz-Roux, the focus tends to be more on government and doesn't necessarily recognize the role of healthcare systems or other partners. So I'm a visual person, and I like to take these definitions and sort of reconstruct them. So if this is a schematic of public health, in the center is the local health agency, a state health department, a local health department. And off of that are relationships between hospitals, clinics, and laboratories. Let's see if I can get my little laser pointer to work. I think it's sort of working. So in this standard model, the local health jurisdiction relates unidirectionally with a clinic, a laboratory, and a hospital. Now, when I think of population health, I think of it including hospitals, clinics, and laboratories, but also other partners such as social service organizations, community members, both in terms of individual community people as well as community-based organizations, policymakers, and partners in academia. And rather than that unidirectional relationship, there's more of a bidirectional discussions across all of these domains. And everything is filtered through the lens that, one, health is multifactorial, and two, that population health needs to be seen through a lens of health equity. So now that we've begun to think about how population health may differ from public health, I want to talk a little bit about how we can think about workforce. And I heard this Chinese proverb a few months ago, and I think it is such an excellent example of the way we need to think about workforce in general. So the proverb is, the best time to plant a tree was 20 years ago, and the second best time is now. And this really resonates with me for a few reasons. The first being, it acknowledges the fact that we probably should have done a lot of things a long time ago, but it pivots us to a place where action is now, and that we need to begin working even though there were deficiencies that we may have identified in the past. So in terms of workforce, we're thinking about different pipelines in order to get the kinds of people that are skilled and technologically prepared to work in the current multidisciplinary health, hopefully health equity focused population workforce. And because we're thinking about these pipelines, we need to think of both about that tree that we should have planted 20 years ago, as well as what we can start to work on now. And I've divided the pipelines in this schematic into sort of 4 general bins related to about the age of individuals and their schooling. So in order to supplement the population health workforce at the high school level, we need to make high school and middle school students aware that population health is even an option. I'm trying to remain more optimistic in 2020. It was 2022 was one of my New Year's resolutions. So I feel like COVID, thankfully, one of the bright spots, the few bright spots, is that I think a lot more people know what population health and public health is and are interested in careers, but we have a lot more work to do at that younger elementary and high school level. At the undergraduate level, we need to continue that awareness, as well as identify ways for population health to be integrated into undergraduate curriculum, establishment of internship programs, and then also financial support through grants and fellowship programs. At the graduate and professional level, we have formal training programs like Masters of Public Health or other doctoral or master's level training. And again, grants and fellowships are critical to ensure that we're training folks who are not going to be burdened with substantial debt into their future careers. And then finally, for graduate levels, we need to think about promotions and career ladders, that we're training folks and skilling them in a way that there's development for them and that they'll remain in the public health pipeline, both to succeed themselves and help train the next generation. Additionally, as some of my colleagues have mentioned, compensation is a really important contribution here, both in terms of getting folks interested in public health, but also retaining them in public health. And one of the areas that we're really excited about learning more about how to implement is student loan repayment as a way to both entice and retain our highly trained and skilled public health staff. So I want to focus now on talking a bit about what are the population health gaps that exist. What I'm presenting here is results from a publication that examined the PHWINS 2017 survey, which was a survey of public health departments and the workforce. These data are a bit old. Granted, we're eagerly awaiting the new cycle of public health wins, but I think it highlights a lot of really critical findings. And what I want to prioritize or draw your eye to is in the areas of public health informatics specialists and information technology specialists, they represent an increasing small proportion of our public health workforce. Even in a large, big health department, they're only 5% or 1.3% of our staff. In other health departments, they're much smaller proportions. And these are critical roles that I think have been highlighted with COVID, that the need to be able to integrate, absorb, distill, analyze, and disseminate data is becoming increasingly important. From these same data, what we see when changes were examined between the 2014 and 2017 PHWINS implementation is that there's a waning satisfaction across work domains. So as we see here within the public health informatics domain, we saw some increases and then some declines. And I'll point you to these bottom rows, which represent these changes. So when these bars are below this horizontal line, it means that things have declined. And within the public health informatics, we see some pretty substantial declines in more recent years. And I want to keep in mind that this is 2017 data. We also see similar trends in information technology, other public health sciences, as well as clinic and lab. When we look at training, what we find is that training and access to technology are critical for existing population health workforce. So we not only need to train new folks coming into the pipeline, but we need to make sure that the folks that we are currently working with have the skills, training, and technological access that is needed for them to develop and grow. CDC has been approaching the idea of workforce by using this 5 shared priorities. So the first is data for decisions. We need to collect the needed data about workforce gaps and training needs to help inform decisions about population health workforce development. Secondly, cross-cutting competencies need to promote essential cross-cutting skills to complement public health workers' discipline-specific skills. We need to ensure that quality standards for training are being used and using accepted education and training standards to guide our investments towards high-quality products and training programs. We want to make sure that training and decision tools provided public health workers in a way that define their training needs and locate high quality trainings that address these needs. And finally, as others had mentioned, the critical component of funding integration and thinking about ways to integrate workforce development into funding requirements to build workforce capacity and improve program outcomes. Here I'm highlighting a report by the de Beaumont Foundation that looked at building skills for a more strategic public health workforce. And I want to highlight in this figure 1 that the skills listed here are not necessarily the domain-specific skills that we think about in terms of public health training, but more of those cross-cutting skills, particularly around systems thinking, change management, persuasive communication, data analytics, problem solving, diversity inclusion, resource management, and policy engagement. And these are critical regardless of what discipline you're studying at the undergraduate or graduate level, and are increasingly important not just for government public health workforce, but for all of us working in population health. I'm going to end my data slides talking a little bit about a report that came out from the McKinsey & Company that looked at capacity and capabilities among various health departments with respect to areas of expertise. And I'll orient you to this slide. So the larger the circle, the greater the capacity is for this domain. And these columns represent very small, small, medium, and large and extra large health departments. So what we see is that in these domains of health education, across the size of health departments, there's a fair amount of capacity. But when we focus here at the bottom, we see that there are some stark deficiencies. In the domains of epidemiology, in the small or very small health departments, there's limited capacity. And even at the larger and medium health departments, we find non-ideal levels of support. Again, laboratory science is an area where there's deficiencies, particularly at the smaller and very small level. But when we look at bioinformatics, health equity, IT development, and health economics, we see very low capacity regardless of health department size. This is an area that CDC has taken some efforts in, and I wanted to highlight a number of our fellowship programs that are led by folks in our division that specifically address some of these gaps. So with respect to epidemiology, our Epidemiologic Intelligence Service is a 2-year experiential fellowship program designed to train the next generation of epidemiologists. We've also established a laboratory leadership service, which trains laboratorians to work in the public health setting. Our public health informatics program is also a 2-year experiential fellowship program training public health practitioners, computer scientists, and data scientists to work in the domain of population health. And then finally, the Stephen M. Teutsch Prevention Effectiveness Fellowship draws from economists, mathematical modelers, health service researchers to gain experience working with experts in the field and at the intersection of public and population health. Again, all of these are training programs work through the lens of being multifactorial approaches to health and health equity being paramount. I do want to point you, this is a page, the CDC page on all of our fellowship programs. So if you are interested in a fellowship program or want to learn more, they're all listed here at that URL. And then I'll just summarize. As others have mentioned, population health has suffered from decades of infrastructure decline and disinvestment. Action now leverages increasing abundance of resources and broader appreciation for value of population health. The intervention levers at all stages of the pipeline need to be explored and tested to provide evidence-based best practices for bolstering the national population health workforce. And the multifactorial nature of population health and a lens of diversity, equity, inclusion, and accessibility are applied throughout and not separate disciplines or components. Thank you very much, and I look forward to the discussion.
Thank you, Dr. Bernstein. That was terrific, and I really appreciate you highlighting both the distinction between population and public health, which I suspect we'll come back to, as well as really being explicit around those strategic skills that are necessary now. And those were some of the disconnect that I mentioned in my opening remarks in terms of that gap between what our public health compatriots may have experience in, but what they're being asked and challenged to do. So really appreciate you making that distinction.